Shall we go to the next question?
Yes, sir.
Who is presenting the next one?
Sir, good evening, sir.
Go ahead.
Sir, the topic for discussion is on the physiology and aging of anesthetic complications, sir.
Physiology of aging. Physiology and the question is physiology of aging and anesthetic implications.
And the anesthetic implications, sir. Yes, sir.
So, how a person becomes old and what are all the physiological changes that happen in old age? Okay.
Yes,
So,
sir.
it is something related to frailty, what already we have discussed, but something slightly different. Okay, let us see what we have prepared.
Yes, sir. Sir, to start with the definition of aging, aging is going to be aging is a progressive, time-dependent, and irreversible decline in the functional reserve of all organ systems, leading to reduced ability to maintain the homeostasis during stress such as illness, surgery, or anesthesia. So, the definition of elderly is individuals who are aged more than 65 years, and they can also be further classified into young old who are 65 to 74, and old which who are 75 to 84 years of age, and very old who are more than 85 years of age. The physiological changes with the aging in the systematic ways include the central nervous system, where the change is going to be a decrease in the brain mass, which is around 10 to 15%, and the effect is going to be a decreased cerebral blood flow and increased sensitivity to anesthetics. There will be a decreased neurotransmitters such as acetylcholine, dopamine, or GABA, where this will lead to increased delirium in these patients and also slower cognitive recovery in these patients. There will be a decreased MAC requirement around 6% per decade after 40 years of age. Therefore, there will be a requirement of a decreased dose reduction for volatile agents, and there is a decrease in the baroreceptor and autonomic response, which can lead to a fluctuating BP and bradycardia in these people. Also, there will be a decreased EEG activity, which the patient can go to a greater depth at even lower doses. So the clinical implications mainly include there will be an increased sensitivity to the benzodiazepines, propofol, and opioids. Also, there can be a higher incidence of postoperative cognitive dysfunction and postoperative delirium. So the drugs have to be titrated slowly, and pre-medication can be avoided if it is unnecessary. In the cardiovascular system, the changes would be there will be myocardial fibrosis and left ventricular hypertrophy, which can lead to a decreased compliance and diastolic dysfunction in these patients. The arterial stiffness, there will be an increased afterload and also an isolated systolic hypertension. There will be a decreased in beta adrenergic sensitivity, which can lead to a blunted heart rate response to hypertension. Also, decreased baroreceptor reflex, which can lead to an orthostatic hypotension and BP fluctuations. And the maximum heart rate is going to be decreased in these patients, which is 220 minus age. And there'll be a decreased cardiac output, which can lead to a decreased cardiac output and in the stress situations. So the main clinical relevance here would be the hypertension is usually common with induction, and there's a decreased coronary reserve, which can lead to an increased risk of ischemia. And also, vasopressors has to be carefully titrated to maintain the perfusion pressure. In the respiratory system, there's a decrease in the chest wall compliance, so which can lead to an increased work of breathing. The increased lung compliance or the loss of recoil can lead to air trapping in these patients. Also, a decreased alveolar surface area, which can lead to a decreased diffusion capacity. Also, the increased closing capacity, which usually exceeds the FRC around the age of more than 65 years, can lead to the small airway collapse and VQ mismatch in these patients. There is a decreased response to hypoxia and also hypercapnia. There is a risk of hypoventilation associated with it. And there is a decreased cough reflex and also a decreased ciliary function in these patients. So there can be a retained secretions and pneumonia risk for these people. In the renal system, there's a there's going to be a decrease in the renal blood flow up to 50%, and there's going to be a decreased GFR, and there is a decreased tubular function and also impaired concentrating ability in these patients. There will be a decreased renin aldosterone activity, which can lead to sodium imbalance risk. The clinical relevance is going to be decreased elimination of renally excreted drugs, which is muscle relaxants and digoxin, and nephrotoxic drugs should be avoided, and perfusion and hydration has to be maintained. Moving on to the hepatic system, here the liver mass is going to be decreased, which will be around 20 to 40%. And there's a decreased hepatic blood flow, decreased enzyme activity, which is the cytochrome P450 enzymes, and there's going to be a decrease in the clearance of anesthetics. So decreased albumin also can be seen in these patients, so which can lead to increased free drug fraction. The clinical relevance is going to be decreased in the dosage requirement for IV agents and opioids, and also drugs which have an high hepatic extraction, like propofol or radocaine, or is going to have a prolonged action in these patients. Sir, am I audible? Can I continue?
Are you continuing, or you have anything more to say? Or
No,
you
sir.
finished?
Yeah, I'm continuing, sir. I'm continuing. Okay.
Go ahead.
Yes, sir. Moving on to the endocrine and metabolic endocrine changes, there's going to be a decrease in the metabolic rate, which can lead to a decreased MAC in these patients. Also, there is a poor thermoregulation, for which these patients are prone to hypothermia. And also there will be a decreased stress response in these patients. So blunted cortisol and catecholamine response can be seen in these patients. Impaired glucose tolerance, which can lead to a perioperative hyperglycemia risk. In the musculoskeletal and body composition, there will be a decreased muscle mass and also a decreased total body water in these patients. So the clinical effect is going to be an increased plasma concentration of water-soluble drugs, and there is an increased body fat percentage, which can lead to the increased volume of distribution and duration for lipid-soluble drugs. There will be a decreased joint mobility and arthritis, which can lead to a difficult positioning and also airway manipulation. In the immune system, they'll have a decreased cell-mediated immunity, which can lead to an increased infection risk, and also they'll have a decreased wound healing, also increased chances of post-operative sepsis. So to summarize the anesthetic complications in these people, in the central nervous system, the most common complications are going to be delirium and cognitive dysfunction, usually hypoxia, benzodiazepines, and usually caused due to the hypoxia, benzodiazepines, or any deep anesthesia. In the cardiovascular system, they can have hypertension, arrhythmias, or MI. The mechanism is mainly going to be the reasons are going to be decreased reserve and autonomic dysfunctions. In the respiratory system, they'll have hypoxia, atelectasis, or pneumonia due to decreased FRC or decreased cough reflex. And in the renal, they'll have high chances of AKI due to hypertension or nephrotoxic drugs. And also in hepatic, drug accumulation can be seen due to decreased clearance. They'll have hypothermia due to decreased heat production, and they'll have a prolonged recovery due to the altered pharmacokinetics and pharmacodynamics in these patients. And these physiology of aging is results in a diminished organ reserve and altered pharmacodynamics and increased anesthetic sensitivity. So careful preoperative evaluation and also drug titration during the intraop and postoperative monitoring can significantly improve the outcomes in geriatric people. Thank you, sir.
Okay. My suggestion in modifying your answer, what you have prepared is, it's better to describe the cardiovascular respiratory changes first before you describe straight away to central nervous system as the beginning in your description. Because the cardiovascular changes are more common than the central nervous system changes in the normal healthy patient. Okay. So
Okay.
subsequent to the cardiovascular changes only, the central nervous system also gets affected because of the alterations that happen. And when you describe the cardiovascular changes, there is no mention about the vascular changes that happen in the aging process. First and foremost, the cardiac changes are all secondary to the vascular
Increased arterial strength.
as advances. The vascular stiffness that is produced due to loss of elastin and collagen, which causes the vessels to become more stiffer. Okay, and that
Yes.
is the reason why the SVR, that is systemic vascular resistance, increases. And once the cardiac output is pumped, the blood which is flowing into the arteries, they come back to produce what is called a reflection point, which produces or adds to the afterload of the cardiac system. Okay, cardiac pumping rather. So there are two reasons. One is the vessels themselves, they become stiff and produce an increase in SVR. Second is, as the left ventricle pumps the blood into the aorta and it goes to the periphery, these vessels resist the flow of the blood and try to push it back towards the heart, which is called the reflection point. And this reflection point occurs much earlier compared to the younger age because of the stiffness of the vessel. And this also adds to the afterload of the cardiac pumping. And that is the reason why the heart starts enlarging in size even if the patient does not have hypertension. As per the age advances, the left ventricle has to produce more pressure to pump the blood into the stiff vessels. And that causes the gradual increase hypertrophy first, then it dilates, and hypertrophy causes increase in oxygen demand, and even in the presence of well patent coronaries, patients still can suffer because of the increased demand in oxygen rather than supply of the oxygen. Okay, so these
Okay,
are
sir.
all the common changes that happen in the, and the myocyte also becomes more fibrous because of again elastin and the fiber collagen loss. They lose their compliance, so diastolic dysfunction becomes more because they are not able to relax adequately. Okay?
Okay,
So
sir.
these changes first you have to describe, then go to the respiratory system, then
Okay.
consequently you will have to deal about the central nervous system. So I would
Okay, sir.
suggest that you don't start straight away with the central nervous system
Central nervous system.
changes happening, and this way it will be better to go for that one. And of course, you have
Okay, sir.
simultaneously mentioned what are all the implications because of these changes. And but I have compiled them at the end of this description after the aging. So I will just share my preparation, how to, what I feel is a better way of presenting.
Okay, sir.
So the physiology of aging is associated with progressive loss of functional reserve in all organs, but the extent and onset of this vary from person to person. Okay, and you described according to the age, patients are said as old, young, old, and old, and all those things. But it is better to classify the elderly as chronologically old and physiologically old. So these are the two categories, because some patients who may be only 65 may have deterioration in all the functions of all the organ systems. Then they are chronologically not very old, but physiologically they have become old. On the contrary, a 90-year-old man may still go for a morning walk of 3 kilometers, do yoga, climb stairs, eat well, sleep well, and he may not look like a 90-year-old person at all. So chronologically he is old, but physiologically he is quite young. So it is better to classify the aged people as chronological age and physiological age rather than based on the age years. In number of years, it is better to classify them from functional and age-wise classification. And you must know how aging occurs. What is the mechanism? The theories are considered as evolutional and physiological. Under the evolutional changes, there are mutation accumulation, disposable soma, and antagonistic pleiotropy. This antagonistic pleiotropy is nothing but what is happening is what functions are sometimes happening as an younger individual, they themselves may become harmful at an older individual. So that is what is being described as antagonistic pleiotropy. And at the molecular level, there is gene regulation, the codon restriction, error catastrophe, chromatic mutation, and dysdifferentiation. These are all the changes that happen at the molecular level, which also causes the process of aging. At the cellular level, there is a senescent telomere theory, where the chromosomes, what is a telomere? Any idea?
Sir, those are the in the genes, there are nucleotide sequences in the ends of the chromosomes.
It is the end part of the chromosome gene spiral. Okay, so the genes are the spiral arrangement, the end part. So the telomere length indicates the aging process, and free radicals, which also, as we talked earlier, in the process of causing chromatin destruction. Then wear and tear and apoptosis. These are all the things, changes that happen at the cellular level. And system-wise, there is a neuroendocrine factors, immunologic factors, and rate of living factor. And so these are all supposed to be the mechanisms of aging. At least even if you don't expand them or talk them in detail, you have to at least know the classification and mechanism why people become or get aged. And coming to the system-wise changes due to aging, first, as I said, better to talk about CVS changes. And in the CVS, the primary change occurs in the blood vessels, which secondarily affect the heart. So the mechanism that causes the changes in the blood vessels are oxidative stress, inflammation, endothelial dysfunction, vascular cell proliferation, and MMPs are responsible. What is this MMPs? This is called the matrix metalloproteins. Okay, so all these things are the responsible causes for the vascular changes. And the change that happens in the vasculature are decrease in elastin, increase in collagen production, chronic cross-linking, and glycosylation, which causes decrease in collagen and also decreased collagen degradation, increase in advanced glycation end products, increase in intima and media thickness, ultimately leading to vessel stiffness. So the hemodynamic consequences of this vessel thickness are increase in diameter of central arteries, increase in systolic pressure, increase in pulse pressure, decrease coronary filling pressure, increase in afterload, increase in oxygen demand, decrease in early diastolic filling. So all these things are the consequences of these vascular changes. And cardiac structural changes that will happen are increase in wall thickness and chamber size, increase in atrial size, increase in collagen degeneration in cardiac valves, and lipid accumulation and focal classification in the leaflets and annulus and annulus of the annular enlargement, leading to dilatation. And cardiac histological changes are decreased cardiomyocyte number due to increase in apoptosis and necrosis, increased lipid deposit, increase in collagen and fibrosis formation. And the molecular and functional changes that happen are altered calcium binding, decreased beta receptor responsiveness, increase in afterload, decrease in contraction, diastolic dysfunction, and decrease in maximum heart rate. So because of the beta response sluggish, you will not get the desired heart rate compensation. So coming to the respiratory changes, structural changes are parenchymal change due to loss of elastic recoil, decreased alveolar surface, decreased alveolar surface tension, decrease in glandular epithelial cells, decrease in mucus production, impaired defense against invading organisms. Then stiffening of lungs due to reduced chest wall compliance causes decrease in FRC and increase in work of breathing. Weak respiratory muscles, flattening of diaphragm, which results in decrease in FRC and increase in closing capacity. And functional changes because of the decrease in elastic recoil, the alveoli become more compliant because they are easily expandable. And there is a decrease in maximal expiratory flow, increase in residual volume, and initially because of the expansion, FRC increases. But ultimately, the FRC decreases because of the other factors, and ultimately it is the compensator. And there is a decreased responsiveness to hypoxia, hypercapnia, and mechanical stress, increase in VP mismatching, increase in alveolar arterial gradient, increase in shunt, and increase in respiratory rate. Then you describe about the CNS changes. There are structural changes which happen, which is like cortical atrophy, decrease in gray matter and white matter due to neuronal shrinkage, and you will find the gyri become narrow and sulci become wider when you take a CT scan, enlarged ventricles and minimal loss of neurons, decrease in CSF volume and decrease in epidural space volume also happen. So when you give an epidural for an elderly person, you will have to reduce the volume, otherwise it will end up in a very high level of block. Similarly, the CSF volume, because it is decreased, the spread also will be quite high. And increased permeability of dura, decreased diameter of number of myelinated nerve fibers in the spinal root, and decrease in intersphancial distance and conduction velocity. And so the functional changes because of these structural changes are decline in memory, decline in neurotransmitter response to various transmitters, decrease in activity of daily living, increase in chances of delirium and cognitive dysfunction, increased sensitivity to central neuraxial and peripheral nerve block, increased sensitivity to anesthetic drugs. Then the renal system, structural changes are decrease in cortical renal mass, increased glomurulosclerosis. So the glomerular membrane become more hard and dysfunctional, decreasing functional nephrons because of the decrease in the blood flow to cortex, atherosclerosis, and with the bladder, not only the kidney, you have to talk about the bladder, the voiding system also. So decreased bladder capacity, occult obstruction due to enlarged prostate also can happen. Now the functional changes here, decreased GFR, decreased ability to conserve sodium and water, and there is no compensatory thirst, which the thirst feeling also will be reduced. So patients, that is why elderly patients always become dehydrated, because they don't feel thirst like youngsters and they don't drink water, and they don't have capacity to retain water and sodium, so they become easily dehydrated. So a good indicator of renal function, creatinine is not a good indicator because the muscle mass also reduces, so the creatinine will not be a ideal indicator. And there will be decreased aldosterone, which may cause hyperkalemia, voiding difficulties because of the bladder obstruction. Then hepatobiliary system, 10% decrease in the hepatic blood flow per decade of life, which causes decrease in drug metabolism and decrease in enzyme function also. With regard to autonomic nervous system, there is decreased baroreceptor sensitivity, decreased heart rate response to pressure changes, decrease in cardiac vagal innervation. And sympathetic system function, there is increased central sympathetic outflow, increased level of plasma norepinephrine, but decreased clearance is there for norepinephrine. Decreased epinephrine secretion from adrenal medulla, decreased release during stress also happen. Decreased beta adrenergic response to norepinephrine due to receptor down regulation. And neuroendocrine changes are decrease in plasma renin and aldosterone level, increase in atrial natriuretic peptide, decreased vasopressin response to hypotension, and decreased sodium and water conservation, increased chances of syncope to occur. Coming to musculoskeletal, sarcopenia is age-related loss of muscle mass and the muscle strength, decreased collagen production, decreased in ligament elasticity, narrowing of joint spaces, and decreased intervertebral space leading to crowding of the spines, and decreased osteoblastic number and activity leading to osteoporosis. And hematological changes are decrease in bone marrow cellularity, increased risk of myeloproliferative diseases and anemia, and decrease in adaptive immunity. Then immune changes, decrease in number of B cells causing decreased humoral immunity, and T cell function also is decreased, and there is a decrease in the number of CD4 T cells which cause or provide the cellular immunity, and there is an increase in autoimmune and malignant diseases chances, decreased macrophage activation, so longer duration of infection and delayed wound healing if the patient contracts some infection. Now coming to the anesthetic implications of all these 9 changes are, cardiac changes make aging patients liable to hypotension during GA or continuous urachal blockade, and decreased beta receptor sensitivity may cause more bradycardia and may not have the adequate stress response. Diastolic failure may lead to heart failure and pulmonary edema in the presence of normal systolic function. So I think we discussed about that in the earlier discussion. Nowadays we describe heart failure as preserved ejection fraction or reduced ejection fraction. So invariably older people have heart failure with preserved ejection fraction, and they have this is mainly because of the diastolic dysfunction. And LVAH may cause coronary ischemia due to increased oxygen demand. Sorry. Respiratory changes may cause hypoxia due to decreased respiratory stimulus to hypoxia and hypercapnia. And increased closing capacity over FRC may and decreased respiratory muscle strength, easy fatigue of these muscles, all can lead to hypoxemia. And alteration in the shape of the chest and chest wall complaints can increase the work of breathing. The chest wall almost becomes like a barrel with an increase in the anteroposterior diameter and decrease the vertical diameter. And renal changes can lead to AKA in the setting of hypovolemia or hypotension. And hepatic changes may cause delayed execution of drugs leading to prolonged effect, which may warrant decreasing dose of anesthetic of agents or sedative drugs. CNS changes can cause confusion, delirium, post-op cognitive dysfunction, or excessive sedation due to IV agent. And they can become hypothermic due to loss of subcutaneous fat. And venipuncture also can be difficult because of the very wrinkled and very fragile skin, and they can become easily bluish, the skin, because there is no subcutaneous fat support. The skin can easily become bruised and they develop pressure sore much easily. And musculoskeletal changes can cause difficulty in patient positioning for any regional or surgical requirement. Fractures due to osteoporosis if you don't handle them gently, and difficult circumferential blockade because of crowding of spine and positioning also can be happening. Okay, so these are all the answers that I thought of, I think, for this particular question.